We have two esteemed speakers today, and we're going to talk about lifestyle modifications, and we're going to have Nissan Bandali talk to us, a clinical trials nurse with Dr. Bjarnson at Sunnybrook, and Melanie Kerr, a genetic counselor at UHN. I'm just going to introduce them. You don't want to sit, I guess, eh? Okay. 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 So Nissan began her nursing career at the Montreal Hospital for 2 years before graduating from Ryerson. Then she did some pediatric nursing and went to Sick Kids in Toronto in hematology oncology, and then became involved in clinical trials and worked with retinoblastoma with Dr. Jewett's wife, Brenda Galli, and then went to the Odette Cancer Center with Dr. Bjarnson. And Dr. Bjarnson arguably is one of the most famous medical oncologists in Canada, comparable to Dr. Kolswenberger, but maybe not quite as good looking. And Dr. Bjarnson has done some great work in individualized and inhibitive dosing, and we're very proud of him as he's put Canada on the map for medical oncology and TKI therapy. So Nissan has been working with him and was involved in that trial, and we look forward to your talk. Thanks. Do you want me to lower the mic, or? Okay.
I'm gonna have to bring it down, sorry. Okay, so where do I, oh, here. Is that put up? Oh, there it is, okay. Okay, all right. I have 15% left on my phone and my notes are in here, so. My talk today was about mental health and patients dealing with kidney cancer. So your doctor has told you that you have cancer. Your mind whirls with emotion. Suddenly you're facing with a health crisis. Each person diagnosed with kidney cancer and their families go through the shock of being told that they have the disease. It is difficult to experience feelings of disbelief, denial, fear and uncertainty, anger. Why is this happening to me? Guilt, blame yourself. Could you have done anything to prevent this? Oh, thank you. Oh, thank you.
We wouldn't want you to lose
There
your
you go.
notes.
Thank
Okay.
you. Sadness, the loss of your normal health, emotional numbness, depression, being unhappy, tearful, anxiety, about tests, what's around the corner for you. Sorry. And anticipatory grief is what happens. You are faced with a crisis, and you're told that you've got cancer, whether it's a cancer that can be dealt with surgery or can be dealt with or if it's stage 4, you need to you're now living a different life. So with a cancer diagnosis, grief is common, and it's an emotional roller coaster. Whether the loss you're experiencing is tangible, a body part or strands of hair, or intangible loss, such as loss of independence, grief can occur anytime during the treatment and beyond. Sorry. Understanding how the cancer causes grief. Sometimes people become frustrated with themselves for grieving and want the process to be over quickly. But try to think of your loss as a wound and your grief as healing. The bigger the loss, the longer the healing process can take. Many patients experience collateral losses, such as not being able to work or engage in normal activities, having financial burden of treatment, and more. Because the multiple losses and life changes occur in close proximity, grief can continue to grow. Therefore, facing your emotions head on and allowing yourself to grieve will be better for you in the long run. Grieving the past and the future after your diagnosis. It's possible to grieve the loss of future events and things we once looked forward to. For some people, cancer treatment can impact the ability to keep you from attending a wedding or a graduation. This is a major component of anticipatory grief. A cancer diagnosis can remind you of other significant losses in your life, a loss of a loved one through either cancer or any other way. The cancer grieving process, regardless to the loss, the tasks of grieving processes are the same. Accept the reality of the loss, and allow yourself space and experience the emotions of the pain and grief. Adjust to a world without the thing that you lost. From a connection to the thing that you lost without having it stop you from living your life. Support for cancer grief. Remember, everyone grieves differently. This can be particularly difficult when your spouse, parent, or child seem to be in a different places in their grieving process. Reaching out to your support system and using them to help you through your grief is very important. So finding support, your healthcare team can help you find support, referring to a social worker, psychologist, individual or group of counseling. That's very important. There are, in the hospital, in the cancer, and I'm talking about Sunnybrook Hospital where I work, we've got a team of amazing support, family support program, and it includes social work, psychologists, our palliative care team to help with symptom management, and that is available to patients. And unfortunately, I find that it's very difficult when patients are in the process of dealing with their diagnosis and dealing with what's new and what's coming. Sometimes it's very difficult to as a nurse, for me to tell them or discuss with them supports that we have, like palliative care or our social work system. And it's a touchy subject to start with. Some patient groups are available as well through a Wellsprings program, and patients can go there to get either group or individual support. Social networking online is another actually up and coming. Like, a lot of patients are now going online to get support for, and people who understand what they're going through. Like in Kidney Cancer Canada, there's a forum that patients use quite a bit, and it's a very, it's like-minded patients who understand what you're going through and can help you through it, or have already gone through it. They're a step ahead, and you can use that support system. Mindful meditation is another sort of way to find support. Mind and body, physical activities like Tai Chi or yoga, creative outlets, just such as a friend of mine is a social worker and has started to do art therapy, and she works with patients who've gone through trauma, and it's amazing the kind of work that can come out of it, and it's amazing the kind of support that you can get from just expressing your feelings through art or writing or journaling. That's very important. Hobbies and interests, and time with your friends and family. Just lost my notes. When you're ready, this is also a good time in your journey to start talking about advanced planning. And advanced care planning is a process of reflection and communication. It's the time for you to reflect on your values and wishes, and to let people know what kind of health and personal care you want in the future. It means having discussions with family and friends, especially your substitute decision maker, the person who will speak for you if you cannot speak for yourself. It may include writing down your wishes and talking to healthcare providers and financial legal. So this is sometimes the time that that you can take to look at the future. We often don't do that in our regular lives, is to see if there's something were to happen to us, what would we wish in the future if I'm not able to speak for myself. And a substitute decision maker can be an automatic spouse, child, a friend, siblings, or it could be someone that's unrelated and that you appoint as a substitute decision maker. So once you decide that this is going to be the person that you're going to choose, then you decide when that is. You decide when you want to speak to that person or your family about what lies ahead and what you want in the future. It's important to have these conversations when you feel well, not when you're feeling unwell, because then that's the time that you're having a crisis, and that's not a good time to speak about. It's not a good time, but it's a more emotional time. Important to start early, and what's important to you may change over time. And these kinds of conversations should probably be revisited quite often, you know, so that you're able to make sure that your wishes are always at the forefront. Think about what makes your life meaningful, your values and beliefs. Learn about relevant medical terms and ensure that you have full understanding of your own health, both presently and what it might look like in the future. Decide on your substitute decision maker. Happy with your automatic substitute decision maker, your caregiver, your children, your friend, or are you going to choose somebody that's unrelated, say for a power of attorney for your personal or financial care? Talk to the SDM, your family, friends, and healthcare team, and then write it down. Record what you want, and that's very important so that everyone in your health care system knows what it is that you're needing. Pain and symptom management is something else that I was asked to talk about today. With the longevity of treatments now, patients are on, you know, as we've talked about today, you can be on treatment for many, many years. And in those years that you're on the treatments, there's a lot of side effects that can come on really quickly, and then there's side effects that you have to deal with chronically. Pain, fatigue, anorexia, constipation, dyspnea, nausea, and vomiting is some of the side effects that you deal with constantly. And with immunotherapy, we're now starting to see amazing, different types of side effects that are totally unrelated to what we've been used to seeing. And so, you know, it's very important to be able to deal with these side effects with your healthcare team. Palliative care is something that I try to talk to my patients about. And we've got a really great palliative care team. Palliative care is not end-of-life care. Palliative care is an enhancement. And I was talking to Gord yesterday, and I had to change my slides because he said it's not palliative care, it's life enhancement. And life enhancement palliative care in the context that I'm talking about is trying to deal with those symptoms, the pain and the lack of appetite that, you know, your oncology team is there for you, but sometimes we need a little bit more, and our palliative care teams have a lot of things up their sleeves that they can help you with. You know, in terms of, like, I had a patient who was in a lot of pain, and, you know, she started with just the regular narcotics, hydromorphone and whatnot, and then, you know, she wasn't able, and then she got constipated, and, you know, so it was like a cycle of pain. So what ended up happening is that we asked her to see our palliative care team. And at first she thought, I'm not at end of life. I don't want to go see the palliative care team. And I said, you know what, let's try. They also look at symptoms and pain management. And so she did. And I think it was the best thing she did. They put her on a very different type of pain management system. And at this time, it's been about 6 months, and her quality of life has improved immensely. So it's very important, I think, that you know, you communicate with your healthcare team, let them know that, you know, this is what you're going through. And if there's something that your oncology team cannot or needs some more help with, palliative care is very important. Good communication to help make decisions about your care and treatment options. Care that considers your physical, social, psychological, spiritual, and practical needs and the needs of your family. And it's important to look at, you know, not just the treatment that you're getting, not just the physical, you know, I think looking at your relationships that you have with your caregivers, with family. We were talking, Nancy was talking today about, you know, not being able to, you know, talk at first with her friends and family, and, you know, and it took her a long time, and just that ability to cope and grieve and move on. Sometimes you need more help. You need you know, our psychologists that can, you know, that can spend time. And there is also couples counseling, there's family counseling. Those are things that I think we sort of put aside sometimes, and I think it's something that's very much needed in sort of our continuum of care. Taking care of the pain and other symptoms by specialists to keep you comfortable as possible, opening up opportunities for personal and spiritual growth during the time. I think that might be it. So my takeaway is use your multidisciplinary team to be able to get the best out of the care that you can get. We talked a lot today about advocacy. We talked about the resources that we have, and to be able to sort of move through this journey that we can. Any questions? There, that's you. Oh, sorry, I'll go back.
Hello, we had asked this question and we talked about this earlier, and I think she covered it beautifully. Yeah, I'm glad she's using that phrase, life enhancement. It's been something, I've got to cry again. It's something I've been championing for the last 3 or 4 years at Princess Margaret. Palliative care has a very negative connotation. It doesn't have to be. It's not, the end of life service they provide is wonderful. If you're at that point, we're not. But there's so many other things available. No doctor knows all about everything. They have their specialties and they're good at it. Ask them, I need help with, because there's a whole group out there, pain management, symptoms, side effects. That was where I first got involved. There's doctors that specialize just in that. Counseling, financial counseling, personal counseling, suicidal thoughts, they all are there and they have their specialties. Don't be afraid to ask. It'll improve your life. It'll improve your treatment drastically. Thank you for supporting that. And push it in your hospitals. Get them all to change the name. I like that name. Okay, palliative care, life enhancement.
Yeah.
Okay, can be done. Thank you.
I think those are great comments, and in fact, at our cancer center, the Juravinski Cancer Center in Hamilton, we have removed the name palliative care and called it the pain and symptom control doctor. It's a long name, but it's exactly what it is. It's controlling the pain, because palliative care does have a connotation of end of life, and it's not true at all. We get palliative care involved, we get pain and symptom control team involved early on, and in fact, the Ontario mandate, I'm not sure what the BC mandate is, but Ontario mandate is that all patients with metastatic cancer, regardless of disease site, should see a pain and symptom control doctor of some course, sometime during the course of their disease. So it's important for, again, lifestyle, as you talked about, and all these other issues. And I think palliative care is really a misnomer, and it's all just in the name. Removing that name would change everything. And even they're involved in our cancer center. We have our pain and symptom control doctor involved in cannabis as well, right? They prescribe cannabis and so on. So all these things are not end-of-life issues. They're about making you a happier patient.
Thank you.
Good job. All right, any other questions right now? Okay, let's just, I'm going to introduce you as well. Okay, all right. So now we're going to talk about genetics. So there's a lot of research going on in genetics, and Dr. Raymond Kim couldn't come, so we have Melanie instead. So just joking. Melanie Kerr actually graduated from McMaster, my home school as well, and completed her master's in genetic counseling at the University of Toronto. She had an early career in genetics program at North York General Hospital in Toronto, with a primary role in a hereditary breast and ovarian cancer clinic in that time, and then joined the genetics medicine clinic at UHN and Mount Sinai Hospital with Dr. Raymond Kim and she's Dr. Kim's boss. And she works in the Genome Diagnostics Laboratory there at TGH. And she's really involved in the screening. I'm not to take any away of your thunder. I haven't seen your slides yet, but we do have CUA or KCRNC guidelines for genetic testing that's mandated. Anybody under the age of 45 who has kidney cancer should have genetic testing. We've done a poor job of that in Canada, and actually we published a paper out of Ottawa showing that only about 10% of patients who are under the age of 45 with kidney cancer do get genetic testing. So that needs to change, and we're in the process of doing that. If you have a family history of kidney cancer, you should have genetic testing. And if you have multiple tumors, you should have genetic testing. So we have some guidelines, and we're just in the process of educating our oncologists to make sure that those guidelines are followed across the country. So without further ado, we'll get Melanie. Melanie, thanks for coming.
And you are stealing my
Sorry,
thunder.
sorry.
No, geez, Louise. Thank you very much, Dr. Kapoor. So, as Dr. Kapoor said, I'm a genetic counselor. Just for interest's sake, can I get everybody in the room who's actually heard of genetic counselors to raise their hands? Okay, not too bad, not too bad. Looked like about 25%, so that's pretty good. Anybody in the room who's had a conversation with their doctors about a referral to genetics clinics or to genetic counselors, raise your hand. Yeah, not quite so many, right? Okay, so just for the sake of those of you who perhaps aren't familiar with my field, as a genetic counselor, myself, or my people, as I call us, work with clinicians. We work with clinical geneticists or oncologists in some scenarios to sort of help provide risk assessments for patients in terms of what's the likelihood that you may have an underlying hereditary predisposition to having developed the cancer that you've developed, or what is the likelihood that that might be running through your family, and therefore other members of your family might be at risk. Is that the right one? Yeah, okay. Oh, am I going the wrong way? There we go. So just so that we're all sort of on the same page, some of this may be very sort of well-known information to you, but for others it may be pulling back from the far reaches of your memories of, say, grade 10 biology, which has to do with how genetics work and how genes work. So what I'm talking about today is not what was mentioned earlier in terms of, the DNA that's found specifically in tumor cells. So I'm focused, and what we're focused on here is the genetic information that you're born with. So genes, of course, are the instructions. They tell our bodies how to grow, how to develop, how to work properly, and they're found in every single cell in our body. So every gene's doing a specific job. And if we put that in the context of a gene, perhaps, that plays a role in kidney cancer. So this would be a gene that we all have. The job that it does in our body at the most fundamental basic level is to help prevent us from developing that type of cancer. So we all have that gene. We all have 2 copies of that gene, and ideally, both copies of that gene function properly. And therefore, you are, for most of us, with those 2 normally functioning copies of that gene, it doesn't mean we don't have a risk to develop kidney cancer. Anybody can get kidney cancer, but it's a general population risk. When I'm talking about a hereditary form of kidney cancer, what we're talking about is a person who carries from birth 1 copy of that gene that contains a variation. Different terms are used to describe that: a variant, an abnormality, a mutation. These are all sort of the terms that are used to describe that. But it basically means that in every cell of the body, there's an alteration that's causing that gene not to function quite as well as it's supposed to. And what that does is cause that person to have an increased risk of developing kidney cancer at some point over the course of their life. It also means that they could pass that non-working gene on to their children. And in a practical sense, what that means is that for a person who has an inherited predisposition to kidney cancer, there is a risk for other family members to also carry that risk factor, and that is 50%. So there's a 50% risk when it's an inherited form of kidney cancer, and I'll speak a little bit more to that in just a second. There's a 50% chance that each of that person's children, siblings, and parents could carry that same factor. However, and I think this is a really important point that I speak to most all of my patients about, is that just because you carry an inherited predisposition does not mean you're going to develop kidney cancer. And I think that's really important for people to be aware of, because anybody who's a parent in this room, and I have no doubt there are many of you, if you start thinking about genetics and inherited conditions, you're worried about your own health, but what are you really worried about? You're worried about your kids. Right? That's very normal and typical, and what we hear all the time. And so I think it's really important to recognize that just because you carry an inherited predisposition to this disease doesn't necessarily mean it's going to happen. It's a risk factor. So the other thing is, based on that, what we end up with is families that can look like this. So in this family, anybody who's colored in red has kidney cancer, but you'll see there are a lot of other people in this family that carry this big A, and the big A is denoting the gene alteration that's putting that person at increased risk. And you see that while there perhaps, and this is a sort of a small family, but you would see more than expected number of people in a family with kidney cancer. It certainly isn't everybody who carries that inherited factor. So the next question that people always ask is, well, how often is cancer hereditary? And I think that in general, people overestimate the role that inherited single genes play in causing cancers of all sorts. And in fact, this number, this sort of 10% over most types of cancer is kind of the number that we see as being due to these underlying hereditary gene mutations. So what that says is that most people who are diagnosed with kidney cancer will not have an inherited predisposition. It will be what we consider to be sporadic, happens because of environmental factors, other risk factors, perhaps multiple sort of genetic insults that happen over the course of our life, but not due to that inherited predisposition. The other thing that I do like to just sort of focus on a little bit, or touch on anyway, is this idea of family clustering. So we can see cancers sort of seemingly in higher proportions in a single family, but just because people have a family history of cancer doesn't mean it's automatically high-risk genetics. Because there are many things, like I said, that play into the development of cancer. We call those familial cancers. And that's one of the things that genetics, certainly genetic counselors and genetics professionals can sort of evaluate to some extent, is whether the cancer that they see in your family looks like it may fall under that hereditary umbrella, or whether it could be more of just a familial clustering for potentially other reasons. But here's the big question, and this is where Dr. Kapoor kindly stole my thunder, thank you so much, is could my kidney cancer be hereditary? What are the things that we look at in terms of clues? And so, as Dr. Kapoor said, the Kidney Cancer Research Network of Canada published guidelines a number of years ago under their genetics initiative in terms of what are high-risk factors, or what are considered high-risk factors for hereditary kidney cancer. And these are sort of those high-risk factors. So if you're diagnosed with kidney cancer under the age of 45, if you have a strong family history of cancer, especially kidney, but there could be some of these hereditary conditions can be associated with kidney and other types of cancer. So in general, if you have a strong family history of kidney cancer or other, if you're diagnosed with bilateral kidney cancer, so kidney cancer in sort of separate primaries on both sides, if there are multiple tumors, and if you have rare subtypes. And this is not saying that if you meet one or more of these criteria, you definitely have hereditary kidney cancer. That's not what we're saying. These are the flags for us that allow us to say, okay, this is someone that we should think about and that we should talk to perhaps about doing some additional genetic testing. So what is genetic testing? Well, again, there are lots of reasons that people do genetic testing in cancer. We do it with biomarkers, for prognostics, for diagnostics. That's not the type of genetic testing I'm talking about here. I'm talking about blood testing to analyze relevant genes in hereditary kidney cancer to look for these abnormalities or mutations. And what we're looking for is an alteration in that genetic sequence. Because if we find it in the blood, with the exception of the circulating tumor DNA, which we heard about this morning, sort of put that in the back of your mind when it comes to this. Basically, if we see something at a certain proportion, a high enough level in the blood, then we know that it's in every single cell of the body, and therefore it is most likely hereditary. I'm not going to dwell on this. This is sort of something that I can talk for easily an hour. But anyway, basically, you know, if and when you have genetic testing, I think it's important to recognize that there are limitations to what that testing can do. So if you are found to have a positive genetic test result, it means that they've identified a causative variant and confirms that it is a hereditary condition. It means that blood testing is now available for other members in the family who want to know if they carry that same underlying genetic predisposition. And it may have other health implications for you and your family members, because some of these genes are associated with kidney cancer and potentially other medical issues as well. So there may be other screening recommendations that are made. Now, if the result is negative, or sort of when I use sort of normal genetic testing, or if it's inconclusive, because we can certainly get that kind of test result also, basically what that means is that there's no definitive causative genetic variation found in you. What it does not do is rule out a hereditary condition. We have limitations still. We have technological limitations. We have knowledge limitations. it doesn't in and of itself rule out a hereditary condition. So it's important for that result to be put back in the context of your personal situation. And we've heard about that all day long. It's very individual in terms of how we interpret these results. And doctors might still make additional recommendations for you or your family members, even in the event of a negative or normal genetic test result. So just to finish off, I think this is sort of the big issue here, and I think this is what Dr. Kapoor was alluding to, and sort of why I wanted to ask that question at the beginning as well. Access to genetics and genetic testing is fraught with challenges at this point in time, across this country anyway. The first thing is that there are definitely limitations in our resources, and those come in the form of funding limitations, in terms of lab infrastructure and how to actually get the testing done in a clinical diagnostic laboratory. And we have a real shortage of genetics professionals. And I'm just going to ask another question in the room here. How many people have maybe been referred to a genetics clinic and waited for months or years to see someone? Has that happened to anyone? Yeah, so I see a couple of hands up, and that is a real problem in terms of access to genetic counseling and access to genetic testing. The wait lists in our regional genetic centers tends to be very, very long. So what do you do in the interim? How do you get access to that? That's a problem right now. There are regional discrepancies, and you see the same things listed under there, because depending on where you live in this country, you may have easier or more difficult access to this kind of service. I know in Ontario, for example, our government right now happens to have a fairly, dare I say it, liberal policy when it comes to paying for genetic testing to be performed, much of it out of the country, actually. We send a lot of genetic testing to the United States. And it's a huge budget, and they've been very liberal with us in terms of allowing us to access this for patients. Alberta, on the other hand, they have a very tiny pot of money, and that has to be distributed amongst all patients for every genetic condition that exists. And once they run out of that money in a year, it's gone. So if you don't get it in January and the budget's gone, you don't get genetic testing. That's how their funding structure works. So there are challenges across this country in getting equal access to this kind of information. But here's the big problem. There's a knowledge gap. There's a big knowledge gap. And Dr. Kapoor alluded to this. Again, so many thunder steals, I'm telling you. But anyway, there's a big knowledge gap. And the studies have shown that very few people who are actually eligible for genetic testing are being referred and are getting that testing done. And that's on both sides. It's not just patients that are not as aware of this, but it's providers as well. It's oncologists, it's family doctors, it's all providers. And so what I would say is that I would encourage you to talk to your doctor about whether genetic testing is appropriate for you. It's not going to be relevant or informative for every single person with kidney cancer, but if you do find that you meet some of those criteria that were published, then I think it's a very important conversation for you to have with your doctor. And so, there's a few places that you can get information. I've just left some resources here. The Canadian Association of Genetic Counselors does not provide specific information about genetic testing on kidney cancer, but it does provide you with information about where your regional genetic centers are and how to get access to that. And then these other three websites, of course, Kidney Cancer Canada, who does a fantastic job of getting information out to you, has an information sheet about genetic testing, as does the Canadian Cancer Society and the National Cancer Institute. So they're good places to go and start to get information about that. So that's sort of where I wanted to stop. And I know that was longer than 3 minutes, Stephen, I'm sorry. I'm not good at 3 minutes.
That's a great job, Melanie. Well done. Why don't you come have a seat and we'll take any questions. A couple of comments. I guess
And now you're stealing my mic. Sorry. I'm kidding. I'm teasing.
Okay. Boy. All right. See what Dr. Raymond Kim has to deal with.
Oh, thank you.
So one thing I did miss on those screening was, again, we talked about age under 45, bilateral tumors, family history, but also non-clear cell histology. So anybody who has papillary renal cell carcinoma, anybody who has chromophobe renal cell carcinoma, translocation, sarcomatoid, that does warrant genetic testing. So I would encourage your urologist to send you for the genetic testing. There's two ways to do it. One is the urologist can do the genetic testing, and we're in the process of partnering to get that to our own center as a urologist only, or you can get a referral to the geneticist as well. We have, luckily, Dr. Raymond Kim has been very good with seeing our patients within 3 to 6 months. But in Hamilton, our referral to the geneticist is actually 1.5 years. So I think it's kind of a little bit ridiculous. So we're taking on the genetic testing ourselves. So one question I had for you, Melanie, was what about those patients that don't meet those criteria? If they want genetic testing, can they get that done?
Loaded question, a little bit, actually. Traditionally or typically, I would say, while there are always ways to get around the system would generally shut that down. But I would say that the landscape of genetic testing and what's accessible to people in a variety of ways, including clinically certified, sort of clinical grade genetic testing, is now becoming available actually direct to consumer. So there are ways that, now I'm not advocating for that necessarily, although some of these companies as a part of that service also provide a genetic counseling component. So I think that, we need to open our eyes and think about accessing these ways in perhaps non-traditional ways because of the challenge that the traditional method is putting in front of us. Roadblocks, basically. We're hitting roadblocks when it comes to access. So the short answer is actually yes. Anybody can actually access these tests now.
I think part of the help of Kidney Cancer Canada getting some education out there is that many urologists, when they do the surgery for patients, so they're not aware of these guidelines, and so it does behoove the patient, if you guys Kidney Cancer Canada can educate that if you do have these criteria, you should ask your urologist for a referral for geneticists, and I think that's important. And we're also going to do a better job of educating our urology community, because these aren't well known. They are published, but not everybody reads those publications. And my other question for you would be is that if a patient doesn't meet these criteria and wants to pay for these genetic tests, how much would it cost?
Another great question. I like to give credit where credit is due.
I just wanted to jump in before you answer that question to follow up on Neil's comment.
Yes.
We are actually working with Dr. Kim on an information brochure that it's nearly done, and we'll be distributing that through social media and everything, so that it'll be a little booklet that you can actually carry around with all those questions, and so you can actually hand it to your doctor. You can use it. So that's coming very, very, very soon, because you've been working on that, Mel.
Yeah, and my colleague Marta Zabowska, who is working directly she has the privilege of working directly with Dr. Kim right now on looking at alternative models of service to get this information and the service and genetic testing out to the population more quickly, more effectively, and more efficiently. So I think those kinds of information brochures are really, really important. Cost, you asked about cost. So different companies offer this kind of testing for different costs. There's actually only one on the market right now that has clinical grade genetic testing available to anybody. I mean, I can go online and order it tomorrow. They order it through a third-party physician, so you don't actually need to have an ordering physician. And it's around I believe it's around $800 US. There's another company that's been doing genetic testing clinically for some years now, and they're bringing in sort of that direct model into service within the next 1 to 2 months, and their cost is $250 US. It's very
palatable.
It's very palatable. It's different than the $17,000 we used to spend to get this testing done, because using old technologies, we had to go gene by gene, whereas now they can just put a blood sample in, analyze simultaneously as many genes as they want, and so it's driven the cost very, very low, which is important to the healthcare system, but I think also important to the population and patients at large, because it's going to make things more accessible to you that maybe haven't been in the past.
So if it's accessible, then what does that do for you and Neil? And what does it do?
That's a great question.
In using that, I mean, what I'm thinking about is time factor.
What do you do with the information? So when we have these genetic mutations that identify 10% of patients you mentioned, I do have a question about that in a second, though. But of those genetic mutations, if somebody does have it, how does that change the management for their children or for the patient or their siblings? And what it just means is more screening. So if I have somebody who does have that, then I just recommend that the family members, especially the children, be screened with an ultrasound every couple of years after the age of 20. We don't have guidelines about how often to do these, so this is just a judgment call about that, but doing an ultrasound every couple of years, it seems very prudent if you have that mutation. And that's how it changes it, is that you'll just be more apt to catch these tumors when they're small and can be treated with RFA or partial nephrectomy at a very early stage with a very high cure rate. My other question for you then is if 10%, so most of these kidney cancers that we see unfortunately are sporadic. They just happen, unfortunately, even in non-smokers, people that don't drink a lot of alcohol get these sporadic cancers for no good reason at all. And we have some genetic components in them if they're of those criteria we talked about. What proportion of patients that don't meet these criteria have a genetic mutation? Is that a good question?
It's a great question, Anil. Thanks so much. My short answer is I don't know. And I actually think in general, so I love that we're thinking about that though, because I think that when we identify things initially, a term we use is ascertainment bias. So we're always likely to find sort of the most severe, the lowest hanging fruit per se, and identifying it in that patient population. But as we start to do this more broadly, I think it's not unexpected. It won't be unexpected if we find that in fact a higher proportion than 10% ultimately have a genetic or hereditary driver. We just haven't been testing those people yet.
I guess the reason I'm asking that is from a practical point of view, from the patients in the audience here, how many of these people should go out and spend $800 on genetic testing? Well, even though they all look under 45, they may not be.
Yeah. I think it depends if you're an information seeker, right? And I mean, some people would say, the more information you can have, the better. And to say, well, I spent $250 and I found out that there were no inherited mutations that I carry that we can find today. It doesn't really tell you anything, but it doesn't tell you nothing either, right? It means that, okay, well, we can't take it off the table. We can reduce the risk. It's most likely sporadic, and I can relax or feel a little bit more reassured in terms of my family members.
Thank you very much, Nissan and Neil and Melanie.